information in this presentation. And FYI, it will be recorded, so if any of the chiefs or managers aren't able to make it, they'll be able to watch it, or if there's a part that you want to review, you can review it again. Or if there's someone else in your clinics you feel like this would be useful for them to see, they can watch this video. We will be coming to each of your clinics individually to train the providers, and Tammy and Allison Everett will be training RNs and RDs. So, you know, the core people to this workflow will get some individual attention. So this is more of a global overview of the program. So I think I know everyone, but let me do a quick intro. So my name is Crystal Wong. I'm a family doctor. I work at Ravenna, and I've been there since we opened back in 2011. And I'm also the Associate Chief Digital Health Officer for UW Medicine, and am spearheading the remote patient monitoring program for UW Medicine. So we are in our final phase of rolling out continuous glucose monitoring for UWPC, and looking forward to bringing this to your clinics. Mika, do you want to introduce yourself quickly?
Absolutely. Good morning. My name is Mika Mäkinen, and I'm a project manager for the telemedicine team. And I've been assisting Dr. Wong on this continuous glucose monitoring implementation. So it's a pleasure to be here, and looking forward to working with you.
And those of you who have been around the block for a while will remember Mika from when he was the manager at Smoky Point when that clinic existed. All right, Mika, why don't you go to the next slide?
I apologize, I'm having a little bit of issues going to the next slide, but there we go.
There you go. Cool, and you can actually go to the next one after that. All right, cool. And then just FYI, you know, if you have questions, please, you know, unmute, ask questions, or type them in the chat. Mika, I'll have you watch the chat just in case there's something in there that I missed. And then we do have Tammy and Allison on the line, so they're always helpful for clarifying certain points or putting little commentary in the chat. So watch out for that from them. Okay, so I think everyone knows what remote monitoring is, but let me just give you a definition. So remote patient monitoring uses devices to remotely collect and send data for interpretation, meaning good biometric data that actually comes from the patient's natural environment, as opposed to having to bring them into the clinic, and, you know, maybe getting a measurement that's not as accurate as it would have been at home. You know, that's can be the case for something such as blood pressure, especially. You know, us in primary care, we have a lot of commitment to our patients. You know, we are in it for their lifetime, but we only see a small fraction of their life in our office. So this is really able to transport the care team into the patient's home, and all those social determinants of health that are really so imperative for outcomes and patients' well-being. The emphasis of remote patient monitoring is on data monitoring and expanding team-based patient care as well. So getting the rest of your team more actively involved in keeping a patient healthy or on their journey to wellness. So not just so based on the patient that comes into clinic and sees their PCP. And, you know, we do hope that this would be able to replace some patient visits in order to improve just the efficiency of our healthcare system, because I think all of us have seen patients who come in for a visit. It's highly resource intense, and, you know, it's super quick. There's not really a lot to do, and we could have done this in a way that was more efficient for everyone involved. All right, you can go to the next one, Mika. So this is a little bit of a timeline of our journey through continuous glucose monitoring. I think you guys know that CGM has been used for a really long time by endocrinologists. You know, it really is standard of care for patients with type 1 diabetes and type 2 diabetes on insulin. DCC bills out hundreds of thousands of dollars of RPM codes every month for CGM. And this has been available to us in primary care for a long time. In fact, I remember Allison coming and training us at Ravenna like years ago, I think where it's been difficult for this to catch on in primary care are a couple things. One being just coverage and understanding how to get paid for this. But I think the bigger thing is just having workflows in place and a support team in place to help this not have to be a provider-centric workflow. And this is what we're bringing today, really a team-based approach to CGM to make it actually realistic to use in a busy primary care setting. So we ran a pilot back in spring and summer, early fall of last year, and we piloted at Ravenna, Winsville, and Issaquah. We used the Libre sensor, which is what we're going to train you guys on today. And we had the RNs and the RDs help access data and do some of the collaborative care. We had really, really good patient feedback. About 90% of patients opted to enroll, which is great. And 100% of the enrolled patients in the pilot achieved GMI goal. I'll talk a little bit about some of the metrics. There's a bigger focus on that in the provider-centric training, but GMI is basically the calculated A1C that comes out of the CGM reading. So this is really outstanding and way better than we do in real life for diabetes care. Some areas for improvement and areas that we put work in as we design this final product or this iteration of the product we're rolling out to you is really around workflows and supporting job aids, specifically around getting coverage for the CGM device or the CGM equipment. So we'll talk a little bit about that because we did put some work into that as we designed this. And just interestingly, as we polled the participants in the pilot, 50% of the PCPs and RNs did think that this program helped avoid some extra clinic visits. So, you know, that's great. That's kind of a secondary outcome, but it was great to hear that. You can go to the next one, Mika. All right, so this is really the meat of, actually, can you go back, Mika? Okay, the meat of what we're going through. We'll walk you through the whole workflow. We'll talk about step-by-step what you do in order to enroll patients. So identifying patients, how to consent them, what's entailed in the patient intake, what's going to happen behind the scenes in terms of data submission, uploading into the EHR, how we're going to communicate together as a care team. And then we'll spend a little bit of time just talking about some of the Epic tools we have built out to support this program. All right, now you can go to the next one, Mika. Okay, so this is a Visio that's very busy. I'm not going to walk you through step by step. It's also probably really tiny on your screen. But one thing I want to call your attention to, well, let me first just orient you a little bit to this document. So you can really see that this is team-based care. There are steps for the clinic MA, RN, RD to do right here in yellow. There's the patient responsibility, there's the provider responsibility, and there's the integration of working with your panel navigator there. The area that I think we augmented the most after the pilot based on feedback is this area where you see this little, like in the provider swim lane, there's this green arrow and there's this red arrow. And I think the most confusing thing was just getting patients coverage for the device if they have Medicaid or Medicare. And so we really fleshed out that workflow, and through Ellen's partnership and work with the prior auth team, we actually have agreement that the prior auth team is going to help us with coverage. And so there's actually a workflow that Allison and Tammy spend more time with the RNs and RDs about how to get this coverage for certain populations. We are going to talk a little bit about tips and tricks for coverage as well in the provider meeting, because there are some, things you can do to make it affordable for your patient. So anyway, so you guys have this Visio. Mika's going to send out all of these documents, and I'm going to share with you some links so you know where you can get all the individual documents that support this program. So if you do want to spend some time looking through the Visio, especially as clinic leaders, just thinking about who you need to check in with, et cetera, you can look at this Visio. You can go to the next one, Mika. Okay, so first and foremost, what patients are a good fit for this program? CGM is becoming very, very prevalent. You can see this picture of this cat. This is Aaron Beckstrom's cat, Peanut Butter, who is not feeling good, and their vet prescribed Peanut Butter a Libre. So that's peanut butter wearing a Libre. Peanut butter has diabetes, FYI, diagnosed it using the sensor. So eligibility, exclusion criteria, defining the right population. This is really important for the pilot, and it's really important in general for remote patient monitoring. Selecting the patients that will be successful, that this technology will actually be helpful for. So I think this is a little bit of like a learning hump too, I think, for those of us who haven't done CGM before yet. But the criteria for use of CGM actually is quite broad. I think in our minds, we think diabetes plus insulin equals CGM, but it actually is quite more broad than that. So patients who are eligible meet one or more of the following criteria. So obviously they have diabetes, and in the primary care sector of using CGM, we're focusing on type 2 diabetes. I'll talk a little bit about type 1 diabetes later. So type 2 diabetes, and they might be on insulin, which would be cool. I mean, this could replace their finger sticks. That's awesome. But they don't have to be. They could just have difficulty with glucose management, and they may be wanting to tailor a lifestyle, someone you just diagnosed. They may be on oral meds, but want that positive feedback or negative feedback, whatever, that real-time feedback of what lifestyle is doing. So really the use case is broad. Now, I also want to just mention, just because this might be a good fit for the patient, for their own personal goals, for their disease management, et cetera, doesn't mean that it's necessarily going to be covered by their insurance. So I think those are two things that you kind of have to divorce in your mind, okay? We did want to be very clear about what patients would be excluded. So number one would be type 1 diabetes. And I know all of us take care of some patients with type 1 diabetes in our practices, but because this is a team-based workflow, and type 1 diabetes is just a little bit more complex, we didn't want to make this program have to encapsulate that. That just added a lot of variables. So if you have patients with type 1 diabetes, and for some reason they're not seeing an endocrinologist, and you think CGM is a good fit for them, then you could consider using it for them, but then you would be managing that. You're not going to bring in your nurse and your RD necessarily. Okay. Additionally, patients who receive care from an endocrinologist for their diabetes, whether it's type 1 or type 2, and this is because of the billing criteria for CGM, you can't double dip. And so if you have a patient who has diabetes and is seen by endocrine and are interested in CGM and their endocrinologist has not put them on it yet, just tell them to talk to their endocrinologist. Again, this is really bread and butter for endocrinology, and then they can put the patient on the program and they can do the billing, and we won't get kind of this double dipping risk. We're also excluding pediatrics and gestational diabetes. This is really kind of a newer technology. It's not yet FDA approved actually for gestational diabetes, even though the high-risk OBs do use it. And then, a kid who has diabetes, that probably should be managed by endocrinology anyways. So we're keeping it simple. It really is type 2 diabetes that are managed in the primary care setting. Okay, other good ways to find patients that might be a good fit. So I think all of us are having panel management meetings, really looking at the list of patients who are on your diabetes list who maybe are not meeting goals. So that's a good patient to maybe think about. And then, just have a conversation with your population health team to see how they want to integrate, mining for these patients. You can go to the next one, Mika. Okay. So you've found a great patient. The patient wants to do this. They're engaged. Typically, this will happen in an office visit, whether that's in person or telemedicine. But, we find patients all over the place. Maybe it's through panel management. You're looking at your list and you're like, oh, maybe this person is good. And, you have a conversation with them, whatever. You have a patient. Now, what do you do? Okay, so first and foremost, because we're going to be billing for this program, your RN and RD are going to bill for their time. You're going to bill for the interpretation of the data, et cetera. You need to consent the patient. And so we have a nice generic RPM consent. This can be used for any RPM program. One thing we would like to roll out in the future would be blood pressure management in RPM, and you can use the same consent. You can consent the patient in a phone call or e-care message. Obviously, phone call is a back and forth live conversation. If it's an e-care, or sorry, to replace this MyChart message, you do have to have that back and forth. Like, Mr. Smith, I think this would be a good program. Here's some information. You know, we will be billing your insurance. Do you consent to be part of this? And then they respond yes, and that would count as consent because, you know, it's documented in the chart. There was a back and forth conversation and the patient was able to say no, et cetera. After you have the consent down, you will place a referral to RPM, and then there's a drop down in it, and hopefully we will populate that drop down with other programs. We add in more RPM programs, and you're going to use that drop down, just choose CGM, and this will route. This is how your in-clinic team is going to know that you ordered this for the patient. It also is just another stamp in the EHR, you know, for the billing purposes. It also helps us track number of patients who are using RPM, because then we can count it off just the referral data sheet. And then, you know, obviously you're seeing the patient, you're making a decision about their care. There's a clinical plan that is really important that the RN or RD hear about, and you need to route that chart to the RN or RD so they know that, you know, you're enrolling this patient, what's the diabetes plan, you know, just in general, they have the U number of the patient, they can do chart review, et cetera, all those things that you need. And if you want, there is this dot phrase that has a description of what CGM is and what to expect about the program, and you can put that in the ABS for the patient that you just have decided to enroll in this program. One thing I just want to mention, you're going to see me say RN or RD a lot, because I know some of your clinics don't have RNs, and the RD is going to support you, although the RDs are getting more and more comfortable with this. I know Tammy and Elton have put a lot of time working on education and support for this. So just figure out for your individual clinic who you're going to be routing these to. And again, it's going to differ by clinic. So you'll probably just need to have a conversation about that. Okay, next slide, Nico. Okay, so the patient's consented, you place the referral, you put in your plan, the patient needs their equipment. The Libre, if you have a smartphone and you're a competent smartphone user who, you know, uses apps and such, all you need to give the patient are the sensors. If they don't have a smartphone, or for some reason they're not comfortable using a smartphone, then you'll also have to prescribe the reader. So it's very similar to ordering diabetes supplies. Like when you are starting someone on insulin, you need them to check their blood sugars or whatever, you know, you have to order strips and lancets and the, you know, glucometer, blah, blah, blah. So similarly, CGM, you order sensors and you order device if they need it. For commercial insurance and Medicaid, this comes through the pharmacy benefit. So if you just type in Libre, it will pop up like a medication order. That's what it looks like. So again, it's very similar to ordering like test strips and a glucometer, except it's sensors and a reader if they need the reader. And then you would just put in the details and send it to the pharmacy. Medicare is a little bit different in that the CGM equipment is through the DME benefit. So after you prescribe it for them, it needs to go to a medical supply company. So there are a couple ways you can do this. One, you can use a DME form, like you can type in DME and find the DME order. Personally, what I do, because it's too hard for me to remember like too many different things, is I just order the medication, but instead of ERXing it, I print it and then I sign it. And then I tell the patient to go take that to a medical supply company. Like really, they just need something that looks official, that has that you are prescribing it, has your signature and your details as a MD or APP on it. There also is a DME form that you have to fill out for Medicare. In the smart text for documentation, there's actually, in those vanishing tips, there's a hyperlink for you to click, and then it'll pull up the document, you can print it. You know, some clinics have decided they're just going to print a few and just have them in the team rooms or something. So that's also possible if you're going to see a lot of Medicare. Anyway, so it's a little bit of a arduous process for Medicare, let's just say. Go to the next slide, Mika. So in the provider training, and I know Tammy and Allison also cover this in the RN/RD training. We talk a little bit of tips and tricks about cash pay for CGM. So I'm not going to go into that in detail, but just know that, you know, in this day and age where pharmaceuticals are kind of crazy and there's all sorts of like, you know, tricks we help patients with to get things, you know, less expensive, even less expensive maybe than what their insurance copay would be. You know, there's obviously some tips and tricks too around the sensors, and a lot of times it actually might be worth it for the patient to just pay cash for them instead of going through the hoops of insurance coverage. But anyways, more on that in the subsequent training, but just FYI around coverage for the device. Okay, so you've picked a patient, you've consented them, you order the referral, and you put in the orders for their equipment. Now what? Okay, so now this is really going to your support care team. This is what we didn't have before. So, you know, all the materials have gone to your RN/RD. They know this patient is getting enrolled, and they're going to check the chart, and they're going to make sure that you did everything you needed them to, or they needed you to do before they can see the patient. So if they have everything, they're going to do the outreach and then they're going to schedule this in-person visit. We're going to talk about this more specifically in the provider and RN/RD training, just the finer details, but just know that next it'll be handed off to the RN/RD. Okay, you can go to the next one.
Actually, Allison has a point on a chat. She's stating to support Crystal's information about Medicare. It's a little bit more evolved, but the good news is that the RNs and RDs have been trained to assist in a completion of the DME form.
Yeah, thanks for giving that little bit more detail. I mean, this truly is, you know, we're getting more and more experience with this. So, you know, I think identifying the pain points and supporting that with our teamwork is, you know, improving as we continue on. Okay, so then the patient, after they have successfully received their equipment, they will do an intro meeting with the clinic RN and RD. And this is predominantly to train them how to use the device, how to apply the sensor, make sure their app's working, how to sync it, talk about a few little caveats about using the device, such as you need to sync it to your phone at least every 8 hours or you lose your data, etc. And then if they have time, you know, if the patient, you know, is kind of a quick study on how to use this, then they're going to do a little bit of medical history, lifestyle and habit review with them, talk about the individual care plan that you know, laid out for them as the provider, and then, you know, basically kind of do a little bit of education, but that's only if they have time. Potentially they might have to split the visit into two, but the code they're going to bill for the first meeting really is for device setup and teaching the patient how to use this device. So that's really the key takeaway from that first visit. We have a dot phrase for the RNs to use that really kind of guides you through all the steps, etc. Okay, you can go to the next one, Mika. That is just a screenshot of what the note looks like. You can go to the next one, Mika. Okay, so the patient's set off, you know, blessed and set off into the world. They know how to use their device. So now they're going to start working on the plan that that the PCP laid out, right? They're going to wear the monitor continuously. They're going to upload data, and then your team, the RN or the RD, will log into LibreView, which is the online portal, and bring that data into Epic so the ordering provider can see it. So there's going to be a couple things that happen. One, the full-on AGP report will be PDF'd and put in the media tab. Two, some key metrics are going to be put into a diabetes flow sheet. And again, there'll be lots of training about those details. And that's so the ordering provider can just kind of look at the metrics and trend them over time without having to go into, you know, the media file and like, you know, write down manually what the GMI was, you know, this and this and this. Then they're also going to put in a message to the PCP just saying, okay, the the report's in, and here's the hyperlink to it. Here are the key metrics summarized in the body of the note, so that, you know, if I get one, I can just quickly scan it and say, oh, GMI was, you know, 6.1, cool. All right, I'm going to save this until I see the patient and we'll review it together or something. If I eyeball it and the GMI is like 12 or something, I might actually click that link and look at their AGP report right then and there when I'm doing some in-basket time. But, you know, it's just so you can get a quick snapshot. And then there will obviously be a little bit of correspondence between patient and care team, very similar to, you know, how our workflows are for if you have a patient that's in care management or is in BHIP or et cetera. You know, there's always a little back and forth with updates. You know, the next one, Mika. And then we do have some smart text just to help with documentation of that. There's the RN follow-up visit that will have like the, that they'll use every single time they dip into LibreView and pull the reports. There's also a RPM interpretation note for the providers to use, and this hits all the billing criteria so that you can bill out the code for interpreting CGM data. And then there's there's a treatment AVS that you can use to update care plans for the patient. So let's say you're seeing the patient back from their first time after starting to use their device, you reviewed the AGP report, you said, oh, look at this, I think you need more, you know, basal insulin or something, whatever you did, then you can use this AVS dot phrase to put in the diabetes plan for the patient. You can go to the next one, Mika. So this is kind of aggregated all of the Epic tools that here. We have these in a variety of job aids for you guys, but these are all the smart texts that you will need to use some of them. You may want to use some of them. So like the consent is essential. The RN intake note, that's essential. Using the follow-up visit and the interpretation notes are essential. It's really the AVSs, you know, you might have a tool that you like better than using that, but this does have some details. The other thing that these AVSs have in it, and this is for if you're having patients that have Medicaid or Medicare and you're trying to get coverage for the device, is there's some language in those AVSs that have I don't know, just some magic words to get it covered, basically. Like, this is medically necessary. You know, this patient needs frequent adjustments of their insulin. This patient needs to check their blood sugar more than 4 times a day, et cetera. So it does have that language built in. So I would say definitely if you are seeing a patient who has Medicaid or Medicare and we're going to try to get insurance to pay for it, the patient's not going to cash pay. It's pretty important to use those then, just so the language is there, so that when chart nodes are printed and sent in, all of that is like stamped in the chart for coverage purposes. You know, the next one, Mika. All right, this is just a billing guide. Again, I'm not going to go through the details here, but this is available. It's pretty simple. The RN and the RDs are going to be billing the majority of the codes for intake and for time-based billing. So basically all the time that they're spending, you know, downloading from LibreView or talking to the patient or typing things into the flow sheet, all of that's billable time, and it's billed in increments of 20. So they will be tracking that and billing those out. The one for the providers to remember is this 95251, and this is the interpretation of CGM, and that can happen every 30 days. I think it's worth 0.7 RVUs too, just FYI, I have that in the provider deck. But anyway, so you can do that in a visit or you can do it outside of a visit. The patient does not have to be live there while you're interpreting it, although you know, I do think it's the best practice to use it in a conversation with the patient because, you know, that's the power of the data. You can go to the next one, Mika. This is just the RN/RD time tracker. Unfortunately, we don't have an auto time tracker in Epic yet. There has been a lot of advocacy by multiple medical systems that Epic would build something because more and more systems are utilizing these RPM codes and they're completely time-based. But for right now, the RN/RD will have to manually track their time and drop the codes when they hit that 20-minute threshold. So the next one, Mika. And then upcoming training, I've already mentioned this, but We have provider training scheduled for all of your clinics. That will be kind of provider centric. I'll lead that. There's going to be RN, RD, and staff training. Tammy and Allison will lead that. And you can really invite whomever. It doesn't have to just be RN and RDs. Like if you want to send your panel navigator to that, or if you have, I don't know, some other staff member, BBC, or someone who's going to be super involved, like feel free to send them to that training, or they can at least watch the recorded video. And then afterwards, we'll have some continuing support. Tammy and Allison host these RPM office hours where they're just there for 30 minutes and you can just jump in and out of Zoom to ask any questions. This is really helpful for clinics as they go live and kind of in between questions pop up. You know the next one, Mika? This is just more details about training. So we already have the PCP training sessions there. We try to slot them through your provider meeting time. We're going to focus on the provider-centric workflows and interpretation of AGP reports, and we'll record this. I know we're kind of hitting like the summer months where a lot of people are on PTO, so no worries if they miss it, they can watch the video. There will be an RN RD training session, and that's going to be group training, kind of all the clinics kind of mushed together. They're going to focus on the device and RN RD workflows. This will also be recorded, and again, post-deployment support. Go to the next one, Mika. There's some additional resources. I will show this to the providers too when I do their training, but Savitha did a very in-depth interpretation CGM presentation that's linked there. It's about an hour long. Abbott has some really good resources on its website. On the provider training, I have another link to a shorter CGM interpretation video that they put together. And then down there on the bottom where it says remote patient monitoring, that is the RPM SharePoint site. So it's got all of our resources, which we have a complete job aid that has all the documents put together. We have some patient-facing materials, like if you want some FAQs around, et cetera. That Visio that I showed you, all of that is on that webpage right there. Oh, next one, Mika. Okay, so next steps, we'll be coming to train a clinic near you. There are 6 of you guys going live this next wave. And then after we finish up CGM, we're going to revisit hypertension in whatever way, shape, or form that's going to be in. And then we've already completed the tier 1 and tier 2 trainings. You go to the next one, Mika. Questions? Was everything I said really that clear? I feel like I talked really fast. My throat's really itchy now. Okay. Well, we'll be coming to talk to you in more detail. If you have any questions that come up in the interim, please reach out. We try to make this as close to other workflows we already do as possible to try not to scramble everyone's brain. And please, lots of feedback, as you roll it out. Oh, and maybe just a couple questions that have come up as we've done these trainings. One, this is not like we're watching you, we're counting numbers. Okay, so this is really just another tool for your toolkit. I do think that it's a really good tool to use, and a lot of your patients are going to like it, but we're not like, there's no like quota you have to hit or something. So just FYI, we're also not, I think I got this question too, like, are we doing this for every patient with diabetes? No, we're not doing this for every patient for diabetes. It's really for patients that are good fits and who are motivated and want that. Another question I get a lot that is more provider centric, but what about using this for impaired glucose tolerance? That's really kind of like off-label use, and that's really on the provider to decide if they want to do that. Don't involve your RN and RD if you're doing that. That's kind of outside of this program. But all right, well, I'll give you guys some time back. Oh, do you have something, Katie?
I do have a quick question. Have most of the other clinics had both an RN and RD when they've rolled this out, or have some of those clinics had vacancies. And I'm just kind of curious, Fremont, we don't have an RN here, but certainly have an RD, and just curious how that has worked.
Yeah, that's probably a great question for Tammy and Allison.
This is Tammy. It's been rolled out in clinics that do not have an RN, and it's worked well because the RD takes it on. So I wouldn't worry about if you don't have an RN. The RDs are, and actually Christy that's working with Northwest, Allison, and she's awesome. Yeah. She's very proficient in this. So she's great. So it will work just fine.
Okay, thank you.
And I can just jump in and say, Deb at the Belltown Clinic has done a lot of CGM education and is really competent with filling out the DME paperwork, helping with that and such. And Nikki is at the Issaquah and the Federal Way Clinic, and she's been schooled on all this as well. Whitney is a certified diabetes educator at the Shoreline Clinic and has a lot of experience in CGM, and will be there to assist Lisa as she is, they've done a lot of this divide and conquer kind of as they're getting started. So yeah, I think the main take home is when the providers, it's just so critical, as Crystal mentioned at the beginning, that the provider, when they're placing the order for RPM, to CC the nurse or the dietitian at their clinic, and then that gives that staff member a heads up that there's somebody in the queue. So if there is a clinic that doesn't have an RN, that to make sure that it's CC'd to your clinic RD.
Hey, Allison, do you mind saying something about the delegated diabetes protocol and CGM? Because that's another hot question we've been getting. And the answer is yes, you could do both, but
yeah,
it would be better coming from you.
Yeah, so we have the diabetes competency medication adjustment policy and procedure. So a physician or an APP that has delegated, there's an order. It's called the nursing medication adjustment. If they click that box when they're in meds and orders, that for a particular patient, there might be some patients that the provider does not think it would be prudent for the RN or RD to be adjusting diabetes medicines. But if they do, they just click that box. And if the patient is being seen by the dietitian or the nurse, and they're looking at the download and they see right away that from their intake as well, that the patient isn't taking their metformin as you prescribed, they can, say things like, yes, start taking your metformin and things like that. So that has been a helpful component in this. Of course, as part of the workflow process, all the notes go to the provider for their review and their assessment. And then the provider can get back and say, increase more, or reduce, or so I don't know if that's helpful, but yeah, working together.
Yeah, thanks, Allison. I think just with the plethora of tools out there, it can be kind of confusing for people. So I just want to make sure everyone knows that they're not exclusive. So you can do both together. In fact, it would be a great option to do both together. All right. Well, thanks everyone for your attention and your time. Mika will be sending out materials so you have them at hand. If you have questions in the interim, please let us know. Otherwise, we will be around to train your team members. You guys have a great day. We'll see you later.
Bye.